It looks like everybody's here again.
Okay.
Maybe we can just.
So yeah, sorry for the snafu. And Baihan, why don't you launch in with your talk?
Sure, of course. Let me share my screen. All right, let me present my slides. All right, first of all, I'm Baihan. I'm from Columbia University and IBM Research. I would like to thank David for the invitation. It's a great honor to actually share my research as this highly innovative community, especially more so when I'm talking about learning health system, which is not only a hot topic and also like a long-term vision for many people in the healthcare domain, as well as a topic, emerging topic of interest here at Brigham Women's, as I heard. So I'm also very looking forward to the discussion after the session on all those related topics, if we do not have time, and even more so like offline as well. So the topic of my presentation is called Towards Autonomous Learning Health System in Neuropsychiatry, a reinforcement learning and real-time AI paradigm for patient care and outcomes. Before I start, I want to thank my amazing collaborators over the years, all the way from universities like Columbia and the University of Washington, and also industry partner like IBM, Microsoft, Google, and also my clinical partners at Mount Sinai School of Medicine, MD Anderson Cancer Center, Boston VA, as well as Elizabeth Seton Children's Center. Yeah, so without their support over the years, I wouldn't have made it to today. And many of the research that I will present today is also done in collaboration with them. All right, so I already briefly mentioned about my overall research, which is building autonomous learning health system powered by first intelligent agents as digital twins or computational models of complex biological, cognitive, and social system, and how can we build better therapeutic interface with real-time digital measurements and also NLP and large language models as well in healthcare setting. So without further ado, let's dive into the topic. So first, a learning health system. So many of you are already familiar with the concept of learning health system, where the knowledge generation is embedded into the clinical practice itself, which in turn also improve the knowledge that we can collect through the entire practice. So usually it actually looks like this flywheel with three main components: the data that we will be collecting, and also the knowledge that we can gain either through either on the mechanistic understanding of disorders or how would be the best clinical practice. Then we can distill that knowledge into clinical practice, and then the entire thing will improve on its own as a flywheel. So from a more data science and machine learning point of view, I would like to separate it more into the data components on how we collect those data, and then there would be a model where it will be learning upon the data that we can collect from the patient, from other auxiliary data, etc. And also on the clinical practice wise, it would be trying to ask the question, how would the model give us the better prediction on what you should do in order to maximize certain end goal, right? So in order to optimize and build a better learning health system, we will need to first go from a more data first perspective on, can we collect better type of data, right? Can we have higher resolution, high throughput, and also more temporal resolution that we can extract, and also how to build better parameters, how to go from the data, either the physical data that we are collecting, the semantic data that we are collecting from the interaction with the patient, and how to go from that and parameterize them into the model that we are building such that they are interpretable for the clinician with actionable insight. And another challenge is the optimization problem. If we have built such a model, how can we learn from new batches of data? How can we optimize the model such that it can have better and better prediction for our clinical purposes? So my previous research has been building upon methodologies such as natural language processing, large language models, speech analytics, as well as analyzing multimodalities of data, ranging from neuroimaging or even audio-visual recordings of someone in psychotherapy sessions. And also on optimization wise, I'm trying to propose reinforcement learning as a major solution if we want to make this learning health system to be entirely autonomous, to learn adaptively on its own. And also I have done research in human factors, meaning how our human beings as users are interacting with different computer interface, different AI interface with data visualization, new media, etc. And on the data-wise, most of my recent research has been upon how can we utilize cheap sensors for real-time digital measurement, as many of the measurements, we cannot wear a functional MRI machine in everyday life, but we could be using a mobile phone or other type of recording to actually record how you see, how you are saying things in real time. And also unsupervised learning, more on how do we extract out spatial temporal trajectories and make sense of them. So I want to first introduce this concept of digital twins, which come from aerospace engineering. Since in space shuttle, if you go into the space and you want to fix something, you cannot just cut open something, similar to a patient, right? So you would have to have either a physical or virtual replica of the entire model system, such that you can perturb things in your simulation before really doing the interventions in real time. So this is especially more discussed in the healthcare setting, because patient, you cannot also cut open things as a trials and error. But instead, we want to build more mechanistic and personalized models for our minds, which is how we are thinking, as well as the bodies, in order to match on how their abnormal states would be. So from a more machine learning point of view, to translate into the machine learning problem, we will be going from a certain level of data, and those data can be neural data, text data, anything. Then we will build in some sort of models. Many of the model can be deep learning model recently, because they have been the most powerful predictive engine. And also, then it will be given some clinically relevant predictions for us. Either it's more personalized future predictions, or even how to generalize to new scenarios, or what would happen, what if those counterfactual hypothetical simulation about certain intervention will have certain effect, or certain drugs will have certain effect. And those predictions will in turn improve how we collect our data. So I like this analogy of going from digital twins, and I want to connect it to how do we build better learning and health system. So I believe that usually when we collect the data, we go through the literature, either from the biology, neuroscience, or psychiatry point of view, or psychology point of view, what type of data that we are usually collecting, either through experimental design or for other things. And then we will be having some sort of AI. And in this case, digital twins, the end goal would be, can we build a mechanistic emulator of a certain brain process or a disease process or something like that? And the prediction will be the healthcare domain problems that we are trying to solve. And usually, most of the research in the field has been invested on how do we use off-the-shelf solution like ChatGPT or this convolutional neural net directly and apply onto AI for health, AI for neuroscience, for computational neuroscience and everything. So can we just do them, analyze our biological data automatically as if they are just yet another machine learning task? This has been very powerful already. So I want to further argue that we can do more to it. When we are thinking AI as a mechanistic emulator or digital twin, we can utilize insights from literature of biology and psychology and to inform the AI as some sort of universality of this model system. Well, the healthcare, when we are analyzing different population domain, it offers it more individualities. So as a result, if we were to build an AI model for the healthcare, which is a generalist AI, meaning that this AI system can help us do a bunch of different clinical tasks instead of individual models, then we can learn from biology and psychology, neuroscience and psychology, for its architecture, learning rules, and how we can build this AI model, whether it's a deep neural network or things like that. And since it's gonna be like an agent, when I talk about agent, I just mean those intelligent beings as AI that can have certain actions or predictions. So the healthcare data that we can collect, either it's the patient population, how they are performing, or even in the individualized level, can actually place those AI agents onto a spectrum. So as a result, going this approach, we can build more both mechanistic and contextual learning health system that can have compositional generalization. By compositional generalization, I mean it can have compositional knowledge that we can reuse and interpret, and also it is a generalist model that can do a bunch of tasks, like some sort of foundation model where you train on all kind of heterogeneous data set, and then you can ask it to do any type of task that you can imagine. So what are we looking at when we are talking about these things in neuropsychiatry? So I'm separating it into certain core values that we're focusing on, the solution space, the feedback that we are usually extracting, as well as the outcome we finally want to improve in the patient. So I will not go into specific detail due to the time's sake, but just to say that many of the core values are dependent on the context that we want to basically really help the patient. Like we maybe want to have early detection, because most of the psychiatric illnesses actually arises even before adolescence. So if we can detect them earlier, it will have a huge impact. And also for the treatment and intervention, maybe we want to have more real-time measurement and support, and to support our already evidence-based therapies. And also for the long-term care facility aspect, can we also focusing more on the quality of life beyond those patients who are going into the division of psychiatry, but maybe they go into other specialty like oncology and other things, but they also want to maximize their quality of life afterward. So can we also focusing on those psychosocial effects as well? So the challenges over there have three. So one is, how do we measure those core values as matrix, right? How do we measure those? And also, how do we build a learnable, therapeutic, and personalized interface given those matrix? And third, once we have those interface, how can we learn and optimize the models that drive those interface, given the feedback and outcome that we can potentially even measure more, right? So my past work has been covering a subset of these models, and for the next 3 slides, I'm gonna briefly mention, elaborate on the question, and then dive into the research question. So first, how do we measure the core values? So in many other specialties like surgery and other things, usually when we want to measure the clinical outcome, meaning how can we reduce the morbidity or mortalities, it is not necessarily well aligned with what the patient really cares about, which is their quality of life, which comes from this patient-reported outcome. But it is even more complicated in the psychiatry perspective, where we are measuring 2 parts. So one is those data or measurement coming from brain dysfunction, like those psychophysiological measurements, those biochemical, even the genetic profiles and structural measurement of the connectivities. And also we have a more, not necessarily subjective, but more interactive data that we're collecting, kind of like the psychiatric interviews, or you ask them to fill out a lot of clinical instruments or questionnaires as some sort of self-regulated or reported measures. In these recent reviews, it has been pointed out that although the self-reported measures so the self-reported measures sometimes, although it's already well-defined by the clinicians, as such, the test-retest reliabilities are usually higher than those real-world measurements in behaviors or even physiological measures. But these 2 clusters, they are not really connected. But in this case, if we want to utilize all kind of data, we would want to bridge those 2 different type of measure in a very seamless way, right? We don't want to build more and more self-regulated measurement and instruments and to cover more and more things. But can we go from the more noisy, but maybe more real world measurement and directly map them into the other clusters? And here's an example on how do we build an interface. I will have more details later, but here's an example of a psychotherapy AI companion system which I built. So each one of them, they are kind of like a large language models, where it is also powered by reinforcement learning, where it recommends recommend to the therapist or psychiatrist what next topic that you should talk about in real time. So meaning that this will be kind of like a third person sitting in a room where it's just gonna give the clinician some recommendations because based on the discussion that you just have 2 seconds ago, maybe you should dive deeper into his or her relationship with his mom or something like that. So those are some recommendation system, treatment plan recommendation system in real time. But you can also fine tune them with specific conditions, like anxiety patient can have a specialized model of itself, depression and schizophrenia can have another one. And also you can tune the model such that it can be driven by different therapeutic purposes. Maybe you want to increase the bonding between the doctor, the therapist, the clinicians, and the patient, or maybe maybe you have in a different session in the cognitive behavioral therapy 15 weeks program. Then another week the focus is about the long-term goal, right? You want to align the therapeutic goal. Then what strategy you should be taking. And the good thing about this is that you can not only do data visualization to interpret those insights, you can also have real-time feedback from the clinician based on the next feedbacks from the patients, so that it will self-correct the model entirely on the fly. So this example has been currently we are launching in collaboration with Mount Sinai School of Medicine, where we want to deploy the system into their group therapy setting, where this agent can hear simultaneously, say 5 or 6 different patients or their parents or adolescents, and analyze in real time their separate trajectories. So, but I just want to point out that it might sound easy, but it's more challenging from the machine learning point of view. I'm just illustrating in an analogous example of in COVID, how can we inform a government's policy prescription on those non-pharmaceutical intervention plans? So there are many analogies to psychiatry, but here, basically, I want to point out is that the action that your agent is trying to prescribe is not just whether or not you should use this drug or that drug, but it's about not only you should use this drug versus that drug, and you should follow up in which frequency or go to which therapeutic plans or all those things. So similarly to here, you can close the school in different levels. You can also shut down the traffic in different levels, but they will have a combinatorial effect where they all affect each other. So it's not just a simple one variable random controlled trials, clinical trials, but in real world, you're dealing with all this type of decision making in high dimensional case. And even more complicated, you want to optimize for multiple objective functions. Maybe in this case, we want to both minimize the COVID cases, COVID spread, but also we want to minimize the cost or the stringency that those strategies have imposed on the government resource. So in this case, for a working professional, for like a working mom, maybe she wouldn't have time to go to like a daily therapy. So you need to adjust the therapeutic program based on other values that they might adopt. So the underlying algorithmic problem is very challenging. So how do we learn them? I would propose to use reinforcement learning. For those who are not familiar with reinforcement learning, it usually involves the AI as the agent taking an action to an environment. Well, the environment will be not only given a reward feedback to the agent saying that, well, you did this action right because because the state just migrate into a better state. So basically you are changing the states. In this case, the environment might be a patient, right? If you're prescribing certain drugs to the patient for depression patients, and if the patient has a reduction of its depression symptoms, then you have a positive reward. So the agent will learn through this single interaction how to be better at prescribing future actions. And how does this relate to a generalist learning health systems? So I'm separating them based on the sensing part of this learning health system, if it is entirely autonomous, as well as the learning part, basically how the model adaptively learn on its own, as well as the acting, meaning that how it makes a decision. So patient X follows up, and the Dr. Y might prescribe a paroxetine. and the patient X will be reporting a fever. So in this case, the state just got updated. It's being census again, sent to the learning health system. And then the learning part might be having all the meta information involved and try to translate it into the language that this AI understand and tries to update the agent. And the agent will be able to prescribe the next action. Maybe, you should cut the dosage because you have side effects out of that. But the point being made is that this sensing and acting part can be done in the same agent or same generalist model with all kind of like heterogeneous feedback, like or states or data input, like not just patient follow-up, maybe it's intake videos or family reports or even doctor feedback or even its GPS or EHR updates will all update the generalist, the learning health system. And the learning health system can do prescription, recommendation, admission of a patient, discharge, interventions, even the conversational chatbot, like a ChatGPT, to the patient and their families at home as a feedback collection mechanism could also be done in the same model at the same time, and it will be updating by itself. So to translate to the problem in reinforcement learning, basically we want to actively learn what data, what better data, what more informative data that we should be collecting in the next batch for this very patient, as well as the reward on what is good, what is bad, and also how to optimize the policy such that it can improve the patient outcome better and better. So this mechanism can be adopted to different stakeholders, such as not only in the clinical setting where we may have interventional systems, but also in the home setting where there are secondary support system, and even in the public health setting, where the same RL-based agent can perform different levels of health systems at the same time, and all drawing from the universal data source that a hospital or a hospital consortium will be storing, and even those public data available to the general public as well. So I want to focus on the mental health problem because it is not only a global issue, but also more critical and complicated in women population and gender minority, and also amplified in maternal health, which is one focus here in Brigham, and also even more so in other comorbidity, like in cancer patient. How does this mental toll to their caregiver, their family members, before diagnosis, during treatment, and end of life, even after the survivorship? So there are many issues over there. But traditional method so far has been focusing on using off-the-shelf solutions, like those off-the-shelf solutions and machine learning model, which are generic for similar problem. Maybe you have a segmentation model for your medical imaging, but this model might be generic for other image segmentation as well. And in order to interpret them, you need to have post-hoc interpretation mechanisms to better help you understand why do the model extract out this component and mark it as cancerous or the part that you should take the lesion off. Well, our approach that I'm proposing is more driven directly by the neurobiological theory itself and tailored for the emulated system, in this case of our brain, and should have a one-to-one clinical implications. So here is a very schematic of how this approach would look like. We start from a text-driven model. It should be highly predictive, like a deep representation. And can we find out some one-to-one mapping from certain layers or computational units towards certain psychiatrically relevant correlates, such as some symbolic representation that people can actually make sense of? And also, can we also map them towards the neural correlates, which is our brain representation? Which brain function at which moment is doing this task, it's processing this information, such that this same model can be both useful because it's highly predictive and also actionable with interpretable insights. However, trying to create a mind machine of our own is very complicated. The scale of the neuroscience that we can tackle with can go all the way from the microscopic scale of genes to molecules, synapses, neurons, all the way towards even behaviors, personalities, and in the society level, how human and human are interacting with one another. Those who are interested in deep neural network and deep learning can map the Mars 3 level into the neurons and network and behavior level, which is the most well-studied versions. So over the years, I have studied different ways to build those mechanisms into AI models. Can we have better brain-inspired AI algorithms? Those are not only useful for mental health or healthcare problems that I will be presenting, but also useful for other state-of-the-art machine learning tasks, such as question answering, computer vision, even controlling the drones, satellite image processing, seismic detection, and all those other tasks. But even if we complete the entire threads, we still have other challenges, such as the spatial and temporal scales. How are the brain development being mapped here? How do we model an adolescent brain versus an adult brain? How do we account for the evolutionary developments and also the subnetworks of the brain, and also other adaptation and continual learning across the lifetime of a human being? And even more so, is deep neural network model the model that we should be using to model those processes? As I'm pointing this out, because there is still, although those deep learning model like ChatGPT and GPT model are super powerful for all those crazy intelligent things, however, they still have a huge distance to map from the brain, because the brain, for one, deep neural network model will require power, massive power during training and testing. Those are in the kilowatts of power, but the brain, it only costs 20 watts, and also can have few shot learning is the norm, and can develop from a single cell instead of like you manually create it. And also it will not forget things for most of the time. So I want to point out 3 strategies that will be the best way to help us get started to create neuroscience-inspired mind machine for health. The first one, which is, I think, the attention mechanism is very critical. And this attention, for those who are familiar more in the data science aspect, is not the attention mechanism talked about in natural language processing literature, which is a misnomer and not really relevant too much in the neuroscience perspective. So I'm more talking about in the neuroscience aspect, the external and internal attention, how brain process information. And I believe the reinforcement learning mechanism is the one that we should be adopting for those brain-like AI models as mechanistic emulators. And I would like to point out also the language is the window towards the mind and the gateway for us to potentially do interventions and modulations for those type of AI models. So the slide example are 2. So the first one is an example of reinforcement learning models with biological priors. The second example is how do we use cognitive priors to do natural language analytics. So the first one is how it's grounded by neuropsychiatry. The second one is more on computational phenotyping and automatic annotation in clinical settings. So first, as a brief introduction, for the time case, I might go faster in this route. So we all know that many of the prediction error and values are represented in multiple brain regions and moderated by physical dopamine signaling, and it drives motivation, approach, and action selection. And usually it has a separate anatomical architecture for processing the positive encoding, the positive reward, kind of like the reward versus the penalty, or the basically fight or flight behavior. And then it's moderated by the striatum, cortices, or other things. However, this reward processing mechanism itself is already a very good phenotype that we can map out, if we can map out, to distinguish Parkinson's, addictions, Alzheimer's, chronic pain, dementia, ADHD, etc. But from an evolutionary psychiatry point of view, interestingly, those mental disorders, they are simply extreme points in a continuous spectrum of behavior and traits. They're developed for various purposes during the evolutionary process, so that they are not necessarily bad or anything like that, meaning that somewhat less extreme version of those traits can actually be beneficial in specific environment. An example would be ADHD with its fast switching bias into the reward may be very good to survive for survival purposes if you're in a very dangerous scenario. Therefore, if we can modeling those disorder-related reward bias, we can lead to better AI system, not only for machine learning tasks, but also for our mental health diagnosis as well. Attention mechanism. attention mechanism basically is anatomically separate from the processing system. It has a bottom-up passive attention and top-down active attention. And the main point here is that it constrains and biases the reinforcement learning. And the reinforcement learning also shifts the focus of attention. So it's a two-way interaction between attention and the reinforcement learning mechanism. So this is an example how I build AI model, which is a deep learning model driven by multi-layers of reinforcement learning to mimic both external attention, how someone's sensory units is paying more attention to the saliency of certain objects or certain things in their stimuli, versus the internal attention, which is how the information is routed in different brain regions. Right? Maybe you think that this information has more towards the emotional setting. So that's why that you will route information into that brain region even more so. And how do you learn the entire thing adaptively? So this model has shown to be very powerful in different AI settings. And then how can we build better attention-driven reward as well? So what does the attention tell us about the reward that you should pursue something on the utility or the economic choice and other things? And also you could have more regularity or more passive attention, such as this unsupervised version of attention mechanism, where higher level brain region, they send top-down feedback to encourage the selection of the most relevant information given the current input. And those things, unlike the more traditional Bayesian assumption, a recent hypothesis is saying that the more irregular, statistically speaking, a stimuli is, the higher the information that will endow, and thus the high firing rate of those group of neurons will be even more so. So this is also relevant to the implicit dimensionality of the conceptual space that we are looking at. So I will skip this just to say that it outperforms baseline across different machine learning tasks when you just model this more neuroscience inspired version. So I want to focus more on the modeling psychiatric disorder part, where usually we have different. So here's just an example of the full spectrum of reinforcement learning. We already talked about the full reinforcement learning problem. A simpler problem would be the contextual bandit, meaning that the action has no consequences to your state. Or even more so, in the multi-arm bandit setting, there is no state whatsoever. So you are just trying to make a decision based on whatsoever. So you are always taking the same decision. However, we already know that anatomically speaking, how our brain processes positive reward information and negative reward information in entirely different pathway. So as a result, they should be having a more two-stream mechanism. However, when humans are making decisions in their decision-making, they are still adjudicating among the trade-off between what they can gain versus what is the risk upon them. So you should still have to have a hybrid representation in this case. I will skip the algorithmic detail just to point out that having this simple framework, you can already map out different type of clinical condition based on say their literature. For instance, you can parameterize based on its weights on past positive rewards, the current positive rewards, or the past negative rewards, and also current negative reward. And you can map, for instance, for ADHD, it will be having a very myopic views on how they perceive the good or bad of certain things because it has a very short attention range. Therefore, their parameters will be smaller. And if having patient data, you can even do Bayesian regression to come up with those reward parameters such that you can directly do diagnostic just based on its decisions. And this is just to showcase that these three types of reinforcement learning, unlike other AI model, can mimic human decision-making trajectory with different mental disorders. And here is a more figurative example that I'm just trying to show. So this agent, they are trained with different reward biases of different clinical condition. And I just want you to focus on chronic pain, which is on the second row, the first column. So it doesn't care a lot about the reward because it's in pain, but it will always avoid the ghost. So it will survive indefinitely but basically it's trying to have this avoidance being captured in this behavior as well. Well, the addiction is fearless, right? It never escapes the ghost, but it constantly eats the dots. So they both survive, but they have different strategies that we can potentially mimic. So ideally, hopefully, we can even have patients to play a certain behavioral trajectory game, and we can basically monitor their conditions after that. Okay, I want to then talk about the NLP aspect. Many of the diagnostic or monitoring of the clinical conditions come from this clinical instrument where you have a questionnaire, you fill out something. However, there is also other people saying that psychiatric research is in crisis because most of those evaluations are subjective. And sometimes if you go into a session, if you go into an interview, not interview, but in a psychotherapy session, just 5 minutes into them, maybe the doctor will already prescribe you a drug without doing any physical test. So maybe we want to have more objective clinical tests to also augment the current practice of psychiatry, which is why that the National Institute of Mental Health proposes this research domain of criteria framework to move into more functional domain. And I just want to point out the usage of cheap sensor data to also like speech or text or how people are talking to capture the neuropsychological features directly. So the example that I'm going to showcase is this working alliance, the therapeutic working alliance. It is one of the most successful predictor of outcome of therapy, no matter which type of therapy, no matter which type of clinical condition that you are usually have. It affects the commitment to continue the treatment and also following the direction, which is why that it is very important. So it has been shown that no matter which psychiatrist that you are seeing, most of the case, the reduction of the symptoms is highly correlated with the stronger alliance. And the alliance is usually in 3 scales. One is the agreement on the treatment goal, and also the development of a bond between the patient and the doctor, and also the assignment of the task itself, basically whether or not you are clear with the subtask that you should go forward. And also there is even more interestingly, there is a temporal resolution that sometimes the strengthening of alliance can be indicative of the performance of your entire clinical treatment, even more so than the alliance itself. And also there are different relational structure. For instance, if you are a child and you're working with parents, caregiver, and therapists, and you have all kind of like pairwise alliance that you should be measuring that is completing the entire story. And for many cases, not only it is very important for different therapy, and also it can be the therapeutic itself. And also more complicated relationship can be in cancer patient. Maybe they have longer time period with different therapeutic purposes. How can I basically model them in better resolution, right? The problem here is that most of the people, most of the therapeutic alliance, it's basically evaluated just every 3 or 4 sessions, or at tops every sessions. So by the time, maybe you already spent thousands of dollars, and also for the patient wise, for instance, for psychosis and for their cognitive behavior therapy for psychosis, if you don't care about working alliance, you can even be detrimental to the treatment instead of being helpful. So my proposal here is that can we infer the working alliance from just the inventory itself and in a real-time fashion so that we can have for the first time a turn-level resolution of how we can monitoring how the dynamics of this patient-doctor relationship. So here is its working alliance inventory. And the component that we could have is this type of transcript. Maybe we record it in real time and we can diarize it into who speak at which moment, and then do speech recognition in real time. And then we know what they're talking about. Then we also have these working alliance inventories, right? And also their scoring function when we are trying to come up with the scales. And then we can map it into a deep document embedding. It's a class of language models and deep learning model where you can map out the similarity of sentences or documents just based on how they're saying. So we can map it into this low dimensional space of documenting embeddings, and then different turns and inventory will be computed. And then you can compute a score based on their similarities, and then we can compute based on the scoring function such that we can infer it in real time. So here is how the whole framework is. Right, so we have different working alliance inventories, and those working alliance inventory can offer us real-time monitoring and clinical interpretation, as well as you can aggregate it to further do classification. For instance, you can have some GPT level model to help you to diagnose it into certain condition versus another one, which is now receiving a best paper award in one of the top AI conferences. And also, interestingly, this methodology can also apply to be any clinical instrument, like Becker Depression Index, or even patient health history questionnaire, or other things. You can use any of them. Doesn't have to be working alliance. So the validation is on this ALEX3 data set with a lot of sessions with 4 clinical conditions. They are well-trained therapists without outcomes. And here is one of the results where the different roles are different conditions like anxiety, depression, and schizophrenia. And the first column is patient, the second column is therapist. And you can already see that there are some distinguishment in the turn level within a session. You can maybe already diagnose the patient based on the trajectory of its alliance score. Like the green curve, which is the bond scale, it actually all improves over each session for the anxiety and depression, but not so much for the schizophrenia patient. And we observe a different pattern in the therapist one as well. And you can also aggregate further to find out the propensity of different type of clinical condition in terms of their working alliance scales with respect to either the patient scale or the therapist scales. And then we can provide further interpretable insights with topic modeling method, where topic modeling method is where you go through a data set and you find out what are some major topics being discussed. And then you can have some principal component analysis to extract out the most prominent 3 topics being discussed. And then you can go back to your data set. Here, I'm just showcasing a diet of these interviews, psychotherapy interviews, where the T means therapist, P means patients. And you can extract out the top therapist and patient turns for those principal topics, and then do interpretation. One way could be that you just feed it into the GPT model, and then you ask them to offer a more bias-free representation of what those topics are. Maybe in this case, in this data set, the first topic I'm about emotional states. The second one is about personal experience and decision-making. And then you can extract out the strategies those well-trained clinicians usually adopt when they are talking about certain topics, as listed here. Maybe it's validation, encouragement, understanding, or self-reflection, etc., etc. And then you can even correlate it with the working alliance so that you can offer a better understanding of how talking about each moment at which moment can have what effect on their patient-doctor relationship or working alliance itself, so that you can map it out into these 3-dimensional spaces where you can have on the left, we have the working alliance space and colored by different conditions. The orange one is the suicidal cases, where you can see it is diverging from other cases from the start. And we also have found a significant difference in detecting suicidality just based on the working alliance itself. And we can also see the anxiety and depression actually all merge on the decreasing side of the working alliance in the bond scale at first, then diverge on the task scale, which also indicate their differences. So this tells us that maybe within the 10 sentences of your session, we might already diagnose you into certain conditions just based on how aligned you are with your clinicians. And on the right, we have the topic space. And then you can correlate them and find out that maybe if you are a therapist working with a depression patients, and maybe if you want to emphasize on your bond scale, you should talk more on principal topic 3 instead of 2, because 2 will give you a red square where the other one gives you a better thing. So you can have very actionable insight for the clinician just based on the data set. And then you can even come up with the trait-like and state-like predictor based on their personality types of their conversation, which I will skip. So here is some classification example and how we can also have more interpretation with neurosymbolic models. And I just want to, I want to conclude this research by just saying that in the long term, I'm imagining the working alliance manifold in a dialogue space lives in this manifold, where this manifold, you could map out different historical session trajectory onto this manifold, and then backtrack into the critical events to get insights on exact time points where, say, here we have a dip in the bond scale. So you have a rupture event. So what's going on? And then you can see, okay, that moment, the patient says this, which makes perfect sense. Well, in another session, you look at the breakthrough events, and then you can look at what's being talked about over there, and then you can get insights afterward. And then you can also do real-time. I know we're at time, so I want to first make sure how much time that I still have before. I still have around 5 to 10 minutes around materials, but I want to make sure that everyone is okay before I go into even more safety.
Yeah, thank you. Why don't you?
Oh, okay, sorry.
Can you hear me?
Okay, I'm so sorry. I just noticed my speaker have a battery died. So can you say again?
Yeah, that's okay. Can you hear me now?
Yes, I can hear you now. Yes.
Why don't you quickly, in 5 minutes, blow through the rest of your slides so we at least know what the content is without going into the details of each slide.
Okay, sounds good. Yeah. So sorry.
No, that's okay.
The speaker.
No, we lost time in the beginning too.
Okay, cool. Yeah. All right. So let me first minimize this. Okay, I will fly through in 5 minutes. All right. So if you are at start of a treatment session, and then you have 2 treatment plan, which one you should take, and you can roll down the hill and know what would be the outcome if you are taking a certain treatment plans. And then you can use reinforcement learning to learn an optimal strategy to maximize this reward. However, this is challenging because the patient therapeutic landscape can be a dynamic maze. And even if you identify the therapeutic states, we need to find the best strategies. And in those cases will be an anticipated theory of minds of the patients, sometimes even the clinicians as well. So that's challenging. I want to briefly mention about AI companion system given this, right? So you can have a recommendation agent to recommend to the patients and given different states. And then here currently we are trying to launch this AI augmented group and family-based CBT with Mount Sinai. So here is how this one system looks like, which I just mentioned a little bit. So it will be automatically diarize the speakers on who speak at which moment. And then it will be trying to annotate on how your working alliance scores are and also what topic that you are currently being discussed after being trained on a historical data set. And then the clinicians can actually accept on the topic that is being recommended on speaking versus not, and then so on and so forth. Yeah. So here is another one on speech analytics. How can we enhance the communication? How can we go from those patients who has communication disorders like autism, cerebral palsy, and speech and disorders or neck cancer? Can we improve their quality of life with speech analytics and reinforcement learning? This is in collaboration with Elizabeth Satan. And lastly, here we have this Lancer Commission that I'm part of on the cancer and healthcare and health systems. So basically, my role over there is to go from mobile apps open text, basically how they can type what their experiences are, and go through some NLP and large language models to actually extract out their outcomes and also separate them by countries, cancer type, and demographics. This is in collaboration with MD Anderson, Cambridge, and University of Hindenburg. And lastly, for entertainment purposes, I just want to point out that psychiatry can also help AI scientists. So this is a research that I done where can we use psychotherapy for AI? Can we solve the psychiatric conditions of ChatGPT? So here we have AI therapists and AI chatbot and how we can talk to each other. The AI goes into the therapist room and then we can correct for it. And then basically it makes the AI model safer and less toxic. So that is the goal of that. So finally, I just want to say that this is towards a bio-inspired AI framework for neuropsychiatry, where we can map on all 3 levels. And it can also have our intelligent interface to be more neuroscience aware, where we can have biological and cognitive priors involved and ways to compare our model with those priors. Finally, for digital health, we want to build models that can work for different contexts. We can have real-time annotation, chatbots, companion, and even for educational training, where the weights can be shared among these AI models. And lastly, so we are looking at this real-time AI and reinforcement learning paradigm, where we can iteratively collect the data which are most informative, most targeted, automatically summarize and extracted insight, and also have real-time analytics and intervention plan, and also can update digital twins of not only particular disorders for their virtual screening, as well as for individual patients. And those are relevant to different aspects of psychiatry, like treatment, intervention, clinical assessment, patient care, etc. So my research program that I would like to launch, if I'm honored to actually join the department, I want to work more in the real-time digital measurement side, AI companion side, and also utilizing new technologies such as extended reality, etc., and also other things where we can understand, can analyze different modalities of data to help us to help the clinical practice or the clinical research, and those are related to different aspects as well. So I will stop at my contribution. So that is my last slide. So if you have any questions or